think we have people beginning to join us. So welcome everyone to this discussion today. We are very excited to have you all. We are still waiting on at least one of our speakers. The other is currently stuck on a ferry with some uh, challenges in terms of connecting, but we have the perspective from that individual still being able to join us today through Isaac. So I'm going to share my screen to get us started, and then we can kick off from there. So I hope that is okay with everyone. If I can find my share screen button. Great, excellent. I think we have this going. And actually, Yana, I might actually ask if you can share your screen. Well, while Yana's getting that up for us, as I said, good morning, everyone, and welcome to this session on integrating eye health within community health worker platforms as a part of the broader non-communicable disease care platform. I'm Maggie Dawson from EYElliance, and I'm delighted to be moderating today's discussion. Before we begin, just a few quick housekeeping items. We do have interpretation available as we have one of our members of our panel is a French speaker. So to be able to hear either the French or English, please go to the globe icon and choose the language that you are would like to hear the session in. We do ask that attendees remain on mute, but feel free to introduce yourself in the chat, and we'll have question and answer session at the end. So you're encouraged to post your questions or reflections in the chat throughout the session. So again, welcome everyone. So today, to just frame up our discussion really quickly, we all know that non-communicable diseases account for about roughly 80% of the disease burden. In low and middle income countries. And increasingly, we are seeing that eye conditions are both NCDs themselves and NCD mediated. For example, vision loss can occur from diabetes or hypertension. Globally, more than 1 billion people live with uncorrected visual impairment, and most of it's preventable, easily treatable with a simple pair of glasses. Yet, despite the scale of need, eye health has often been left out of the design of essential service delivery platforms, particularly at the community level. And today we're really excited to share more about how we can think about integrating it better at the community level. So over the past 6 years, EYElliance has worked closely with a number of governments in countries like Liberia, Uganda, Côte d'Ivoire, and Ethiopia, in partnership with implementing partners such as the Clinton Health Access Initiative, who you'll also hear from today, to change that. And together, we've been able to really demonstrate that eyeglasses can be effectively and sustainably delivered through government systems using community and primary health platforms that are already serving the last mile, which I know folks have heard so much about this week in how we can do that most efficiently. So this approach aligns squarely with momentum that we're seeing globally. At the World Health Organization, there's a new SPECS 2030 initiative that have put eyeglasses squarely on the agenda. There's growing attention to NCDs, assistive technology, and disability inclusion within community health platforms. And that we're seeing governments who are going to be represented today on our panel seeing that integrating eye health into CHW programs doesn't compete with other priorities. It actually strengthens them. So the early evidence is compelling. We're really excited to talk about it today, but integrating basic vision screening and the distribution of near vision glasses or reading glasses increases community trust, drives demand for broader NCD care, and improves CHW motivation and productivity. So in short, eye health has proven to be a catalyst, not a burden for integrating primary health care. And so want to get us started just quickly with a few snapshots from a recent trip that members of our team, as well as members such as Isaac that are on the panel and Dr. Jimmy, were able to take to the pilot that is undergoing in Uganda. But just to set the scene for us of what we're talking about in terms of screening and vision. Great. Thank you, Yana, for playing the video. Um, so if we could go to introducing our panelists very quickly. Great. So currently on the line with us right now, we have Dr. Koizen, who's the director of the National Eye Health Program from Côte d'Ivoire. And we'll talk a little bit more about what Côte d'Ivoire is up to in just a minute. We also have with us Isaac Okring, who's a senior associate at the Clinton Health Access Initiative. And he has been working really closely with Dr. Jimmy Oterin, who's a senior medical officer within the Ugandan Ministry of Health as they begin a journey towards integrating eye health into the new curriculum within Uganda. And then hopefully, as we go through today, Olis Verduia, the Director for Community Health Services Division in Liberia, will be able to join us. And then, as I mentioned, Dr. Jimmy is currently stuck on a ferry in the middle of Lake Victoria, and so may or may not be able to join us depending on how connection occurs as things go forward today. So we definitely have some great perspectives on the panel with us, and I'm excited to get going. Donna, if you could move to the map slide. Great. So I just wanted to give a snapshot of where the different countries that are joining us on the panel today are in their journey um, across integrating community health, integrating eye health into the community health worker system and a bit of the process towards doing that. But we've really seen the shift taking hold at the national level for this integration. And each country kind of represented today here is at a different stage of integration, but together they really tell the story of government-led scale. So Liberia was one of the first countries to act, piloting CHW delivery of reading glasses beginning in 2021. And then they've embedded those services into the National Community Health Policy in the last few years, the one that begins for 2023 and was launched at the last CHW Symposium in Monrovia. We've really seen full government ownership, and eye health is now part of Liberia's essential service package under the NCD module as part of that curriculum. Uganda is testing and refining its approach through their national community health strategy reforms. The Ministry of Health, supported by EYElliance and CHI, is evaluating how vision screening and eyeglass delivery can be scaled nationwide, linking data, supply chains, and supervision systems within the broader NCD and PHC frameworks. And they're currently in the midst of a pilot, and we'll have Isaac share some exciting results from that pilot as we continue on. And then Côte d'Ivoire is somewhere in this bottom row, if depending on the day of the week right now. So they're just finishing up the design stage of all of the materials for a pilot in terms of strengthening eye health and how that can be delivered through the CHW platform. But excitedly, Côte d'Ivoire will be launching their pilot to really build the lessons needed for integration in the next week. So Dr. Koizen will be able to give us some lovely details about what they're excited to learn about towards national scale. So yeah, so that's kind of where we stand within all of this. So I'll get started at the earlier stages of this roadmap, and we can start with Côte d'Ivoire and Dr. Koizen to just give us a little bit of a lightning snapshot of what's going on in country. Côte d'Ivoire is actively strengthening its national community health platform, as I just mentioned. And so, Dr. Koizen, could you tell us where you are in the reform process and how eye health is being considered within kind of the integrated NCD and primary care model as the CHW reforms move forward? So I'll hand it over to you to get us started, Dr. Koizen.
Bonjour, chers collègues. J'espère que la tradition passe à votre niveau. Alors, merci Maggie pour la question. Vous m'entendez bien, j'espère. Je n'ai pas une voix aussi. C'est bon le français? C'est bon? D'accord. Alors, je voudrais avant tout donc saluer l'initiative donc de ce symposium et puis également saluer l'accompagnement donc de EYElliance au niveau de la Côte d'Ivoire pour essayer donc d'emprunter le chemin de, de l'intégration des soins oculaires dans le paquet minimum d'activité des agents de santé communautaire et intervenir au niveau communautaire. Euh, j'ai, j'ai une longue expérience dans la question de la lutte contre l'onchocercose, qui est une maladie oculaire que vous connaissez. Et dans cette expérience-là, vous avez pu comprendre combien est-ce que euh, les, les interventions des agents de santé communautaire et également les interventions qu'on a eu à faire au niveau de la communauté ont permis d'essayer d'avancer, de faire des progrès importants dans la lutte contre cette maladie. Également, aussi bien dans les pathologies comme le trachome, qui sont des maladies euh, oculaires et qui ont un véritable ancrage au niveau communautaire. Ceci dit, ça permet donc de comprendre que il est important d'intégrer le rôle de la communauté dans la question des maladies non transmissibles de façon générale, mais aussi de façon plus particulière sur ces maladies que sont les maladies oculaires qui nous préoccupent aujourd'hui dans ce cadre de ce projet. Je sais que ma collègue Dr Kadia, qui est en charge de la santé communautaire, depuis disons une dizaine d'années, il y a beaucoup de réformes qui sont en cours au niveau du secteur de la santé communautaire. On a eu des documents importants ont été rédigés dans ce sens-là, à savoir les paquets minimums d'activité des agents de santé communautaire, la mise en place de plans stratégiques de santé communautaire, des plans de mobilisation de ressources, un certain nombre de documents stratégiques qui permettent d'aller dans le sens de prendre en compte aujourd'hui les questions des communautés dans le processus global de prise en charge de la santé des populations. Nous, la santé communautaire, le docteur Kadia est beaucoup plus, est mieux placé pour aller dans les détails de ces réformes-là à votre niveau. Mais ce que je peux dire, nous, à notre niveau, c'est que euh, il y a beaucoup d'éléments de la santé oculaire qui ont un volet euh, au niveau communautaire. Et donc, la participation des communautés aux problèmes de santé oculaire est très importante, surtout dans l'approche d'augmenter, de susciter ne serait-ce que la demande des soins oculaires. de susciter la demande des soins oculaires. Parce que très souvent, on va le voir au niveau de nos communautés, que la demande même n'existe pas, elle est très faible. Les populations ne demandent pas un certain nombre de choses. Vous prenez par exemple une pathologie qui est comme le glaucome, qui est une maladie silencieuse oculaire, mais il faut qu'il y ait une demande à partir d'un certain âge pour pouvoir faire un certain nombre de bilans, pour aller vers les structures de santé, pour faire des bilans et savoir si nous sommes glaucomateux ou pas et pouvoir commencer un traitement pour éviter le drame, y compris la rétinopathie diabétique, vous en avez parlé. Il n'y a pas de demande de dépistage de la rétinopathie diabétique chez les populations. Et même, quelquefois, on a vu dans les communautés qu'on associe la vieillesse à une baisse de la qualité de la vision. Et donc, il n'y a pas de demande. Pour les populations, ça semble être tout à fait normal que lorsque nous vieillissons, nous devons perdre notre qualité de vue. Alors que ce n'est pas exactement ça. Pour des lunettes de lecture, on peut améliorer notre quotidien, notre environnement immédiat, et cette demande-là n'existe pas. Et donc, un des éléments importants pour nous, nous le verrons, pour le projet pilote que nous mettons, c'est ça va créer, ça va augmenter la demande des soins oculaires, des soins de santé, mais particulièrement des soins oculaires au niveau de la communauté. Et donc, la répercussion sur le système de santé, c'est de voir que depuis le niveau communautaire, depuis les maisons, depuis les communautés, les populations viennent maintenant, font la demande, et ça peut maintenant permettre au pays de mieux mettre en place les dispositifs de prise en charge de ces populations. Parce qu'aujourd'hui, quand vous partez dans nos régions, vous allez voir que les services de soins oculaires sont pratiquement des services un peu délaissés, à la traîne, parce qu'on ne sent pas la demande qui viennent. La fréquentation n'est pas, mais parce que la demande au niveau de la communauté n'y est pas. Donc, je voudrais m'arrêter un peu ici pour dire que les réformes sont faites et nous sommes beaucoup plus focus sur ces questions-là qui nous préoccupent.
Excellent. Thank you so much. And I think you're so right there in terms of demand and what that will do in terms of really sharing how we can build the evidence and the demand for integration and this platform. So really appreciate those insights and again, really excited to see in the next few weeks how everything launches in Côte d'Ivoire. And so with that and thinking about kind of that demand side of things, I think I'll turn to Isaac. And Isaac, as we know, Uganda is testing and refining the delivery of eye health within the community health reforms and have recently, over the last few months, been in the piloting phase. And so I was hoping you could share some of the early pilot results and findings that we've seen in terms of the delivery of eye health screening and reading glasses for those that have presbyopia. And so, if you will, I'm happy to turn it to you and see what factors have kind of made this feasible on the ground.
Thank you so much, Maggie, and thanks to everyone that has connected. Particularly exciting to share some of the early things that we're starting to observe from our pilot. To be precise, we launched out around the last week of August, that's about 24th or thereabout, with the trainings in the sub-counties which have been selected to be part of this pilot. And within the space of about 8 weeks or 9, we've been able to screen over 34,000 people through the community healthcare workers. Most of these people that have been screened actually are people above 40 years of age, although the curriculum specifies or asks the VHTs to screen all people, because we don't want to just, run a presbyopia program, but rather a comprehensive eye health program, which is interconnected to all NCDs across different age brackets and age categories. So the CHWs have been screening all age brackets, including children, and we've reached over 34,000. We've had over 55,000 people failing near vision across different age categories, but those that are above 40 years have been 4,248. In other words, they're forming the bulk of people that are failing the near vision test. And CHWs have been able to dispense to date about 4,100 pairs of reading glasses, which is really remarkable considering that they're doing this alongside their other work, in public health, health promotion, NCD work. It's not like a standalone program, but they're doing it alongside everything else. And I must say, already some of the fears that we had at the beginning are being alleviated already by what we are seeing. As we rolled out, there were kind of, I know we could call them myths about acceptance of the community. Would people be confident in the service that community healthcare workers would be providing? Will they accept screening? Will they accept reading glasses from community healthcare workers? And it's amazing that we haven't recorded even a single incident of someone declining a screening. It's like the community was waiting for this, and because they are seeing immediate impact, and we are getting people even from other neighboring communities looking out for the community healthcare workers to be able to. So the effect is really like trickling down to the healthcare system. There is already demand, and I relate with what Dr. Khoisan said in Côte d'Ivoire. Because the VHTs are starting with health education, general health education, and then they teach you about taking care of your eyes. People are kind of starting to be self-aware. Those that have gone through the process, when they see any small changes in their eyes or the eyes of their children, they are quick to rush to the healthcare facility, and the volumes right from the outpatients have started to increase. And people are now demanding for eye care workers at primary level healthcare facilities, because initially here, eye care workers, most of them are employed as other, clinical officers, and then they have this as an extra responsibility. But now there is a push to have people that are purely dedicated into providing eye care services come on board in the facility. So maybe I'll pause here, but happy to take on any follow-on questions that you might have. Thank you.
Excellent. Thank you so much, Isaac, for sharing that. And I think it leads into the question that we were going to ask Olisford, who's unable to join us at the moment. And so I wanted to just share a little bit about kind of, we've heard from Dr. Khoisan and Isaac where Côte d'Ivoire is just about to launch their pilot. Uganda is right in the midst of that evidence generation. And then we have Liberia, who has gone through this process, and really we are now at this point in country where community eye health and basic vision screening and dispensing of reading glasses alongside establishing kind of referral pathways has been integrated into the new curriculum as part of the new national strategy, and it's in the kind of module for non-communicable diseases. And I think I just want to share a few things in terms of the kind of process that happened in Uganda in terms of updating that service package, and really what led to some of the decisions around integration into the new essential package and the national community health policy. And so, we in Liberia, through the pilot, it really did provide the evidence needed in terms of that CHWs can do this work and that very effectively, as Isaac just shared, can do the vision screenings, identify who needs to be referred, and provide those that need over the age of 40 with a pair of reading glasses. It also showed that there was high demand within the community, as Dr. Khoisan rightly shared, that this is a really important start to the issue. And then, really showed that not only was this a new service within the package, but by by integrating a new service, we actually saw the response to CHWs really improve. It reached populations, particularly men over the age of 40, that had previously not been reached by the community health program in all ways. And so they really started to see the value of the community health assistance within the system, and really through the evaluation that we did, we saw really strong positive indications of improving kind of the status of the CHAs within the community. And so just really quickly, in terms of some of the factors, and then I'll ask Isaac and Dr. Koizen to reflect on some of these. In terms of the factors making this integration to the national program that is going to be rolling out with new training in early 2026, feasible in practice, it really was this really great combination of strong political will, strategic systems design, the evidence generation, and knowing that the workforce could take this on. I think one of the things that was fundamental and is true both in Liberia, Uganda, and Côte d'Ivoire is that this is coming from a government-led and embedded within existing systems, preventing kind of fragmentation or creating new parallel systems for the delivery of a new service. So in Liberia, very intentionally designed within the existing community health system to avoid that creation. So really thinking about policy alignment and timing of when these initiatives happened around both the revision of the National Community Health Program's policies and as well as the National Eye Health Policy, and inclusion in costing exercises so that the backbone costs of running this type of service are being absorbed under kind of existing pooled funding mechanisms that are serving the system. And I just really want to kind of reinforce that, there was then the platform around non-communicable diseases that this was also able to integrate into. And so, as they go to national scale, the feasibility of this integration was really treated as a system strengthening investment, not just a temporary pilot project. And I think this is, exactly how Uganda and Côte d'Ivoire are thinking about this as well. To ensure that community eye health services are riding on the back of the national community health platforms rather than just a parallel system. So that I just wanted to give a little bit of sense of where Liberia is since Olisford is unable to be with us. And so I think I'll turn to Dr. Koizen with my next question, kind of building off of that. And really kind of as you prepare to kind of launch in the next couple weeks, which is so exciting, really want to understand some of the kind of design decisions within the system you're putting in place to kind of ensure that feasibility and a pathway to scale, so that this could move towards a national a rollout under the community health platform.
Merci. Alors, il faut dire que nous attendons ce projet parce que la santé oculaire en Côte d'Ivoire est passée par des périodes très difficiles entre 2016 et 2019 où il y avait beaucoup d'interrogations de savoir si nous maintenons les interventions de santé oculaire en termes de programme de soins oculaires au niveau national ou est-ce qu'il fallait faire disparaître ce programme parce qu'on n'en voyait pas la portée des utilités. Et donc, depuis que nous sommes là, après plusieurs discussions, nous comprenons qu'il est important d'avoir des éléments d'évidence que la santé oculaire est une question importante pour les populations. Et donc, dans cette position où nous sommes toujours en train de, de prouver le besoin de maintenir la santé oculaire, des projets de santé oculaire pour les populations, l'avènement d'un tel projet est une fois encore de plus un projet qui va venir renforcer cette preuve sur le terrain et auprès des populations qu'il est encore, la santé oculaire a encore sa place. Alors donc, ça entraîne aussi la question de la durabilité. Donc pour nous, ce lancement est un lancement important, est un lancement important qui va permettre encore de donner de la visibilité en termes de besoins de services, de prestations de soins oculaires auprès des populations. Et l'audience de cette activité auprès des populations va encore une fois de plus rehausser auprès des décideurs l'intérêt que les questions de santé oculaire suscitent au sein des communautés en termes de besoins. Il y a le besoin auprès de nos communautés, mais il faut des occasions, il faut des plateformes pour les faire connaître. Et ce projet va permettre de faire connaître les besoins des populations. Et ensuite, ça va permettre d'orienter les politiques vers ces besoins-là et de pouvoir trouver une solution durable à ces questions. Sur la question de comment nous réfléchissons pour les questions durables, c'est en cela que le thème intégration est important pour nous. Parce qu'aujourd'hui, il existe déjà au sein des communautés des dynamiques. Vous avez par exemple les dynamiques de la nutrition avec la distribution de la vitamine A. Vous avez des dynamiques telles que au niveau des vaccinations, où on touche des cibles telles que les enfants de 0 à 5 ans, mais qui peuvent présenter beaucoup de problèmes oculaires, les problèmes oculaires congénitales, néonatales et toutes ces questions. Donc, pour nous, intégrer sur un certain nombre de plateformes déjà un plus aux prestations de services qu'on fait auprès des populations ne peut qu'elle-même garantir une certaine durabilité. Et nous voyons déjà que certains de nos collègues des autres départements des maladies non transmissibles nous approchent pour nous dire, est-ce que vous ne voulez pas qu'on intègre des activités de soins oculaires dans cette activité, telle activité? Donc, il y a déjà des perspectives heureuses à ce projet quant à la durabilité. Parce que la demande des populations dans le système de soins met la pression sur les politiques pour trouver des solutions. Et nous pensons que les personnes qui présentent des problèmes visuels et qui ont besoin de lunettes de lecture, d'autres soins simples, mais des soins simples comme des lunettes de lecture, sont des fois très nombreuses. Et très nombreuses. Et ce qui est intéressant, c'est qu'on a des résultats immédiats lorsque la personne porte ses lunettes de lecture, ou bien que ce soit en milieu scolaire, où nous discutons de la question de l'amélioration des résultats scolaires, de l'enseignement. Il ne s'agit pas seulement de l'intellect, mais il s'agit aussi de la vision de l'enfant. Il s'agit aussi de l'oreille. Est-ce que l'enfant entend? Donc, ce sont des questions qui qui amènent des résultats tangibles, des choses que les gens, des changements visibles. Et à partir du moment où on travaille sur le secteur de la santé oculaire qui donne des résultats visibles, que les changements que l'individu ressent immédiatement, vous avez des ambassadeurs pour faire prospérer de telles initiatives et de les permettre de perdurer dans le système. Voilà un peu ce que je peux dire. Je sais qu'il y a beaucoup à développer là-dessus, mais nous voyons des perspectives de collaboration, de plateformes, d'intégration et de la continuité. Et nous pensons que c'est de telles initiatives qui ne peuvent pas s'arrêter. Voilà un peu. Je voulais m'arrêter là.
No, that's excellent. I think you're exactly right in terms of kind of the immediacy of seeing results in terms of the delivery of reading glasses for individuals, and that really does kind of create champions both within the CHWs themselves and the community members. So this becomes a really um, a, an intervention that is well taken up by the community. And I think that in the chat, I was just reading a few of them as this was going on. And Jude, you mentioned that Ethiopia might be missing from this conversation, and you're exactly right. They are also using their health extension worker platform to complete vision screening and distribute eyeglasses, and we've been really it's been really wonderful to follow along with their journey and share learnings from Ethiopia as well. And I think one of the things that in conversations with folks working on that in Ethiopia really has kind of this observed increase for demand that Dr. Koizen is talking about, and demand for kind of the NCD platform overall in terms of, as maybe some in the audience know, Ethiopia has also launched a new NCD kind of module, and eye health is included in that. And so I think, to Isaac, as you've been working on this over the last couple years with the ministry, I'm curious kind of what operational or community level factors kind of playing into this part of the conversation on increasing demand, the immediacy of change that happens when people receive their first pair of eyeglasses. From that, kind of what are you seeing as things that most influence um, whether kind of the integrated eye health and NCD services succeed within the package, and have there been some adaptations that you've seen that are going to be need to be made along the way for sustainability in the long run?
Thank you, Maggie. And, I've really enjoyed listening to Dr. Koizen as well for the perspectives from Côte d'Ivoire. Indeed, we had a couple of factors that some of them we had anticipated, some sort of came sporadically along the way as we moved on. One of them is the aspect of workload and clarity of roles. Community healthcare workers are being asked to do literally everything else. And in our setting, this is a voluntary position. So they also have to earn a living outside, the basic healthcare work that they are doing. And so we had to think through that. What is the extra burden or extra amount of work that's going to be added to this community healthcare worker? And to sort of mitigate that and make sure we are adding as minimal disruption to their routine work as possible, we had to make sure that our tools were really lean and pretty much simplified to the point that they're just, it's sort of just prescribing which steps they are supposed to do without overly complicating things or making them super technical that would take them a little bit of more time to sort of like understand. And we also had to clearly define what the community healthcare worker can do, what they shouldn't do. And, just at the beginning of their screening, they ask some key questions. And, there are certain questions where once it's a yes, they are quickly referring the person. They're not proceeding to, do a couple of other tests for the sake of doing, but, they have also redeemed time. And we didn't ask them to have to do separate eye health visits, but they had to integrate it in their normal household visits, as they go to do follow up on, ANC mothers, as they go to follow up on immunizations, they just also conduct this eye care aspect. And what has helped us as well is the fact that by doing the eye care, processes and interventions, it sort of awakens the community even much more to then take on the other services, whether it comes, it's about nutrition education, whether it's about immunization. Once they appreciate the linkage of eye health to all these other factors, they are motivated to then, take up the other things that the VHs are presenting to them. The other thing that we saw along the way was an aspect of supply. managing and ensuring they consistently have all the supplies that they need. And we had to, make sure there is buffer stock seated at the district and sub-county level, so that whenever they need to conduct a procedure, including dispensing reading glasses, they had buffer stocks and they didn't have to wait for supply to come through, from national level, and thereby lose time. We actually realized VHTs love to work when they have all their tools, ready within their visibility, when they're able to provide an end product to someone. They don't have to refer them again to the facility. It motivates them, and also the community is happy because they're actually able to get the help. The other thing that we had to sort of tighten is an aspect of supervision and data review. As you must be aware, everyone sort of feels good when their data and information is visible. And the Ministry of Health was really interested in this in a way that they had to even communicate the interventions and the work the VHTs were doing on national social media platforms. And VHTs loved to see their work was visible, their work was appreciated. They love to see their work translate into results and efforts that are recognized at national level. We continue to have monthly touch bases with them through their health assistants or supervisors, and definitely reviewing data and providing feedback as and when we notice anything that is significant and that needs to be communicated downwards. We had a couple of community level factors and that have been, drivers for this success. And really, I will tie it down to the involvement of the community, the local leadership, and the community representatives, right from the design of the tools. So we involved them from development of the job aids, the development of the tools. We had representation, community care workers, and within the disability and rehabilitation domain, there is a statement that says, "Nothing for us without us." So all through the the designing of the project, the development of the materials, the planning of the logistics, the coordination, we had the local leadership, both the political and the technical leadership at the district involved. And so they were helping, very, very much helpful in crafting the communication materials, crafting the language within the health education section and segment, and using examples that relate to the people in the community. And so when they see they are very, they're very leaders, it sort of promotes the uptake. And then maybe lastly for now, before even we sent out the VHTs, the community health workers to do the work, we had to do the procedure on themselves. So during the training, we had to screen all the CHWs, those that had presbyopia and were qualified for glasses, received them, and they were the first line beneficiaries, and they turn up to their work, they're able to report better actually, they are happier themselves, and when they explain to the people that they serve, it's coming from a practical and witnessed sort of impact, as opposed to something theoretical that they have read from somewhere else. And the people that see them actually are able to see a difference in their lives as well. So it's really promoting acceptance and the bigger uptake of the service of the community. Maggie, not you.
Thank you so much, Isaac. I think ending on that note right there and opening it to questions is probably a great place to pause and see if the audience has any questions. I think I think if you want to raise your hand, I can give you enable your ability to talk, or you can place a question in the webinar chat. And so I'll see if any hands go up with questions for our panelists about this work, or if anything comes up in the chat. So I'll give a few minutes, but as I'm waiting for hands or anything in the chat, I think that reflection that you're ending on, Isaac, of really being able to create the champions, and Dr. Koizen, you mentioned this as well, of creating the champions within the CHW cadre themselves is just an incredible kind of piece of this puzzle to move demand and excitement for this work forward, and that then is not just for the eye health components, but for the larger components of the CHW program as well. And I think you said it perfectly in terms of when someone receives a pair of reading glasses, they can do their job better and better, and serve the entire service delivery and their community better. So I really appreciate that insight. I'm not seeing any hands for questions or anything in the webinar chat. Oh, I see one in the Q&A. Someone did ask, has there been any cost studies on this? And happy to see eye care from CHWs, by the way. And so I'm happy to take this one on, but Isaac and Dr. Koizen, I would love to hear your perspectives as well on what evidence and cost evidence needs to be gathered. So there have been a number of cost studies done for CHWs. So in any of the pilot work that EYElliance has been doing alongside government, we have been collecting all of that cost data. And I think, one of the questions, if Olisford had been able to be with us this morning for Liberia, is really around, how the pilot generated the costing data needed to go into the CHW costing exercise to really help make the case and show that, this can be integrated and utilize the platforms that are already there to deliver services. And so you're not adding on a whole new set of program costs. You're really thinking about what are some of the smaller incremental costs to delivering eye health, and we'll have some additional information coming out in the next couple months around that idea. And so keep an eye out for it. But Isaac or Dr. Koizen, any reflections kind of on that piece of what do we really need to be thinking about in terms of costing to support long-term integration into the financing mechanisms that are supporting community health, particularly in as we all know and have heard, in a tightening fiscal space for community health overall.
Alors, oui, la question la question des ressources financières, eh bien, comme on le dit en matière de gestion, les ressources ne suffisent jamais. Et donc, il faut toujours réfléchir sur ces questions-là et trouver des solutions durables. Comme la santé, moi, je crois, d'abord, c'est une conviction personnelle. Je pense que la santé, c'est d'abord une affaire de la communauté, avant d'être l'affaire d'un système, avant d'être l'affaire d'infrastructures hospitalières et tout ça. C'est d'abord l'affaire de la communauté parce que la maladie naît chez vous à la maison, dans votre maison, et c'est à ce moment précis, vous êtes seul d'abord à vouloir chercher une solution personnelle à votre état de santé. Et ce que le gouvernement fait, c'est de vous proposer des solutions en termes de système et de chaîne de soins. Ce qui veut dire que on ne peut pas concevoir l'idée de santé sans intégrer la santé des individus, de la communauté, sans les mettre côte à côte avec le système de santé moderne qu'on a. Et je vous ai dit également aussi que je suis d'une tradition des maladies tropicales négligées où, je vous l'ai dit, tous les progrès qui ont été faits dans le domaine des maladies tropicales négligées ont été faits avec le concours très bien mérité des agents de santé communautaire. Et il y a beaucoup d'exemples de maladies sur lesquelles on peut citer l'exploit. Mais vous comprenez que c'est parce qu'arrivé à un certain moment, la population elle-même, la communauté elle-même s'est sentie concernée par cette question de santé qu'elle y a mis une partie d'elle à l'intérieur pour pouvoir participer à la prise en charge de ces problèmes de santé. Je pense que si nous abordons la question sous ce angle, il y a un certain nombre de solutions qui peuvent apparaître, qui ne sont pas euh, forcément des questions financières. Parce que je serais très heureux, parce que vous prenez un agent de santé communautaire que nous avons vu, par exemple, à distribuer des lunettes de lecture. Mais il ne faudrait pas oublier que lui-même est une personne potentiellement qui peut en avoir besoin. Donc, le changement que ce bienfait, que ce projet qu'il conduit lui-même à titre personnel a comme impact sur lui, il a quand même cette envie, cette joie que ce changement aussi apparaisse dans la vie des autres. Moi, je n'ai pas toujours vu la question et les agents de santé communautaire comme des gens qui penseraient constamment à une question de rémunération. Surtout que ce qu'ils font comme intervention, on ne peut pas les rémunérer pour ça. Voilà. Et donc, il y a qu'il faut prendre en compte, il faut mettre dans le champ de la réflexion sur la question de la durabilité des financements, ces questions-là intrinsèques à la communauté qui cherche des solutions à ces problèmes de santé à elle-même. Deuxièmement, j'aimerais dire, comme je l'ai dit au début, il y a les questions d'intégration. Je pense que Dr. Isaac a parlé de la charge de travail, de la charge de travail. Et des fois, quand vous partez sur les plateformes pour l'intégration des services, l'un des défis que vous croisez, c'est la charge de travail complémentaire que l'agent de santé communautaire aura donc à avoir. Et en cela, il a proposé des solutions très intéressantes qui sont importantes à prendre en compte, à savoir que nous devons aller vers un allègement de la charge de travail des agents de santé communautaire. Et c'est aussi une des solutions parce que une des problématiques qui font que on a des coûts financiers qui apparaissent, c'est aussi par rapport à la charge. C'est aussi par rapport à la charge. Parce que quand vous discutez avec les agents de santé communautaire sur un nouveau projet, la première question, ah ben, ça nous donnera trop de travail. Est-ce qu'on ne peut pas prendre un deuxième agent pour le faire? Donc, je pense qu'il y a des questions techniques aussi qu'il faudrait intégrer dans le dossier. Comment réfléchir pour qu'on puisse réduire la charge considérable de travail des agents de santé communautaire, mais dans le sens d'un besoin d'efficacité. Aujourd'hui, tous les systèmes de santé euh, font une demande accrue de données. Il y a une demande accrue de données de la part de tous les systèmes de santé, aussi bien pour documenter les process avec les partenaires, pour rendre compte des progrès et des réalisés. Et toute cette charge de demande d'informations et de données repose très souvent sur les agents de santé communautaire qui alimentent la base de données de tous les systèmes nationaux de santé. Et très souvent, ils sont dans du travail manuel. Il n'y a pas de digitalisation dans le secteur des agents de santé communautaire. Il y a peu de digitalisation. Donc, ce sont aussi des questions. Est-ce qu'il faut avoir plus de process de digitalisation, plus de simplification du travail de l'agent de santé communautaire, puis prendre en compte tout ça? Pour laisser aussi mon collègue, Dr. Isaac, intervenir dessus, je sais qu'il a de bonnes réflexions sur la question. J'aimerais dire simplement que la santé oculaire est un moteur qui qui peut tirer les maladies non transmissibles en termes, comme on l'a dit, en termes de demande, en termes de demande auprès des populations. Et ce n'est pas moi qui l'ai dit, les interventions de santé oculaire présentent de très bons rapports coût-efficacité. Ça, je pense que c'est documenté dans beaucoup de questions de santé, d'intervention de santé publique. Et donc, on peut peut-être changer la tête du train, du wagon, pour que euh, la santé oculaire se mette devant pour tirer toutes les autres demandes. Et comme l'a dit dans le cadre de la couverture maladie universelle de l'OMS, en intégrant les soins oculaires dans les paquets de soins, dans les paquets de prestations de soins de la couverture maladie universelle, on peut augmenter le nombre de personnes qui peuvent bénéficier considérablement de prestations de services de soins au niveau des pays. Voilà un peu ce que je voulais dire pour laisser la place aussi aux collègues. Merci.
Isaac, would you like to just provide kind of some final reflections that you've seen as well, kind of in this space?
Yeah, thank you so much. And I think my colleague has really addressed it comprehensively. Indeed, we realize the community is happy to take on directly some of these costs. For example, we've not had to provide people money to be able to fulfill the referral because they get enough education. And one story that particularly stood out for me, some of the people that were traders, once they received reading glasses, they were able to actually see that they were making losses. Someone told me before he was losing about $2 in a day out of the change he was returning to people. And that for him was motivation enough, even for his colleagues, to look out for the community healthcare workers to check on their eyes. So we've not had to provide them with some handouts for them to accept the service or go out, because it's been really self-evident and important. And because it's still early stages of our pilot, we're being intentional in documenting some of the recurrent costs that we'll need to have to be able to run an effective eye health as part of integrated NCD package or community health services. But also there are some one-offs that, the training costs, for example, and then the supply costs, I think, is really a key one that needs to be taken care of. Otherwise, some of the supervision costs can be integrated into, all the other cost lines that are existing already. And reporting costs, because we're already, rolling out an electronic community health information system. So there are already some, foundational work that has been done, and will not need to incur additional costs. But there are a few costs that need to be taken care of, especially to ensure there is constant supply and the refresher trainings are taken care of.
Excellent. Well, thank you so much, Isaac and Dr. Koizen, and all that have participated today and joined us. What we've discussed reflects, what I think we're all seeing as a broader shift happening across global health, and one that I'm really, just glad to see is happening, that governments are really leading the way in designing integrated, people-centered community health. And it's exciting to see eye health becoming a part of that, and one that is strengthening NCD care, improving referrals, and making supervision and service delivery more effective. I think eye health, as Dr. Koizen rightly mentioned, is one of the most cost-effective interventions and investments that countries can make. And so we're just grateful for everyone's participation. We're grateful to be working alongside so many country governments as they build systems to last, not only for eye health, but for community health overall. And so just want to thank everyone that's on the panel, as well as in the audience, that we thank you for your leadership, your engagement, and your commitment to ensuring that no one's left behind in accessing the care that they need at the community level. So thank you all again. Please don't hesitate to reach out if you'd like to connect with any of our panelists. Happy to put you in touch. I'll drop my email address just quickly in the chat for everyone. It's very simple. It's Maggie@EYElliance.org. And I'd be happy to connect any of the attendees with our panelists today, including those that were unable to join us. So excited for the momentum. And again, thank you so much, Dr. Koizen and Isaac, for being with us today. And everyone have a great morning, evening, afternoon, wherever you are in the world.
Thank you. Thank you all. Bye-bye.